Very good morning, friends. Today we are going to talk about the walking pneumonia. Walking pneumonia. Uh, Actually, it is another name for Mycoplasma pneumonia. We all know pneumonia means really it is a very problematic disease with a dreadful or abrupt onset with high fever, cough, distress, make the child to lie down or bedridden within 24 to 48 hours. But if pneumonia is caused by mycoplasma, the child continue to walk. That is why it's called as walking pneumonia. And we are not going to talk about pneumonia alone. We are going to talk about what is the infection, that is a mycoplasma infection causing syndrome. We are going to discuss about that. You can ask me why you have a special interest on this. Recently, I happened to see this CDC data, that is in 24, mycoplasma surge in US, particularly in young children. In children between 5 to 17 years, it increases from 3.6 to 7.4, and among children between 2 to 4 years, it increases from 1 to 7.2%. That's the reason why I thought we may discuss about this condition. Same time in Japan also reported that there is a surge in MP cases with an average of 2.01 cases with the medical institution. With this background, we will talk about Mycoplasma pneumonia. We want to salute this scientist, Eaton et al. He is the one, though people have started some work on this bacteria, actually he is the one who finally given lot of messages about the Mycoplasma pneumonia organism. It is an obligate human pathogen, 1.2 millimeter. Actually, the size, if you look at that, bacteria and viruses, the size is somewhat very closer to viruses. And still it is a self-replicating organism. That's why it is in the taxonomy, it is placed in the bacteria. That is, it is the smallest free-living bacteria. Though it is aerobe, sometimes it may live in anaerobic condition also. This general view of the Mycoplasma pneumonia, I don't want to go too much about that. Remember what I want to say, that there is no cell wall. Lack of cell wall is a very important feature about the Mycoplasma pneumonia. Because of that, it assumes several shapes, that is pleomorphic. And same thing makes it is intrinsic resistance to beta lactams. That is the reason why some children, if you do not judiciously approach the condition, if you do not think about the Mycoplasma pneumonia, I think even your beta lactams is not going to help you, because it is because of the lack of cell wall, it has an intrinsic resistance to beta lactam. Though it is doesn't have any cell wall, it is having a thick membrane, trilaminar membrane made up of sterols. And we all know originally that it is named because myco means fungus. That is the reason why we thought, the people, all scientists thought maybe a fungus, and that is the reason why it starts with the name Mycoplasma. Already said, because of the lack of cell wall, it assumes a pleomorphic position, somewhere between round, oval, filamentous, spindle. So look at that right side, you can see the spindle shape. That is also very, usually most of the pictures show that that is a scanning electron micrograph, shows that these are the shapes they come across with the Mycoplasma pneumonia. Coming to the epidemiology, actually Mycoplasma pneumonia is the one that happens throughout the world and throughout the year. Though it peaks, the epidemics happen once in 5 years. People say because of the lowering immunity, it occurs as epidemics. And what they say, 10 to 20% of the community acquired pneumonia could be due to these organisms. Actually, the report varies. Some people say even 1%, some people may go even up to 30%. Roughly, you can say 10 to 20%. That may be the correct, maybe nearing to the correct figure. Most commonly, this Mycoplasma pneumonia occurs in 5 to 15 years of age. That is, in young adults are particularly vulnerable to this infection, and it is with a high transmission rates. That is very, very important. If one of them suffer Mycoplasma pneumonia in a family, actually most of them do get infected with this quickly. But the incubation period is very long. Don't expect they get infection within second day, because the incubation period may range from 2 to 3, even 4 weeks it has been observed. Actually, this smallest free living bacteria attach the respiratory epithelium, that is the cilia, by proteins. These proteins are present on the polar region. Actually, I already said it is a spindle-like organism or thread-like, snake-like organism. At one end of that, you can see the attached proteins P1, P30. After attachment, it produces many virulence factors, including hydrogen peroxide, and some toxin is called CORDS, CADRDS, CORDS, community acquired respiratory distress syndrome toxin. All these things makes the cilia damage, getting damaged, ciliostasis, and there is a damage to the epithelium, and it produces a profound inflammatory response locally with liberating all these cytokines. What I depicted is IL-8, tumor necrosis factor, all these things are all produced, and it also induces auto-antibodies. I am going to talk about that little later. These antibodies are acting against the RBCs. Mycoplasma pneumonia, generally what they say, it is a slowly developing syndrome. Usually it starts as a URI, that is upper respiratory infection, starting with a fever, cough, sore throat, fatigue, headache. But one thing, most of the pneumonia, this mycoplasma pneumonia condition, they present with increasing cough. That is very, very important. In my experience also, some people may ask you, what is your experience and all. I say that if anybody comes after 3 weeks or 2 weeks, my cough is not getting all right, after having ruled out asthma and other common conditions, I usually think of, but they invariably it say I am having a body ache, headache, fatigue. But I do work, I do take some normal food and all. That is what the typical presentation of a Mycoplasma pneumonia. This is a very useful diagram for the youngsters, but Mycoplasma is a slowly developing syndrome. Most of them, particularly children, do develop URI. Small percentage may go for a tracheobronchitis, and that is the one that causes a severe, intractable, continuous, persistent cough. Then another small percentage may go for a pneumonia. So I think this broad working knowledge is very important to approach this condition. We will see one by one. In younger children, particularly below 5 years, this Mycoplasma pneumonia present as a URI. Start with something like a viral coryza symptomization. Child presenting with the symptoms suggestive of viral infection, including nasal stuffiness, and they do slowly, children start developing or complaining headache, malaise, lethargy, fever, sore throat. But one thing I already said, the cough may be very intractable, increasing, and many of them actually, that is the reason why it clubbed under virus, and even without antibiotic children may recover. But if you make a correct diagnosis, if your clinical judgment is correct, then put the child on macrolide, the child have a speedy recovery. That is what been told. I think this may not be connected with the topic, but I do want to say, see, first of all, as a doctor, differentiating these two infection is very important, viral from bacteria, but we should all attempt, is it a viral infection or bacterial infection? Because viral infections doesn't require any antibiotics, whereas bacterial infection is the one that require antibiotics. See, most of the viral infections present with leaky eyes, leaky nose, diarrhea, all these things are all the children be affected in the family. That is what the viral picture. But bacterial infections always happen in little older child, abrupt onset with a sudden high fever, and they have a localized symptoms. Either they may have a throat exudates or cervical lymphadenopathy. But where mycoplasma comes means mycoplasma comes in between, or rather I say it present as a viral infection. See, it's something very confuses the physician whether it's a viral or URI. But I am telling you, viral infections usually get after third day, fourth day, child become little normal. Whereas in mycoplasma, day by day, the child may have more cough, lethargy, sore throat. All these things will make you to think of, particularly in the age. I already said no, young adults or older children, you have to think of Mycoplasma pneumonia. So that is why I said Mycoplasma pneumonia is fitting into mostly a viral. So it is very difficult to distinguish Mycoplasma from viral. Again, this is a very useful slide that as a doctor you have to know what are the age related pathogens. That is very, very important, because even though so many advances happen in the field, including molecular diagnosis, you should have a working knowledge. If any child between 0 to 3 months, you have to think of gram-negative infections and chlamydia, all these conditions. Whereas 3 to 5 years, think of viruses, followed by Streptococcus pneumonia, Haemophilus influenza, pyogenes, and Mycoplasma. I think even above 5 years, same thing continues. So that is the reason why I am telling Mycoplasma do come in this in the classification. So you have to think about Mycoplasma pneumonia, and what they say that Mycoplasma is increasingly recognized in younger children also. That is what in younger children, though it present as a URI, some susceptible children do develop some other complications. And recent report says that Mycoplasma pneumonia present as a co-infection. It can occur with the viruses, it can occur with the bacteria, it can with other atypical pathogens like chlamydia or even Legionella. All these things are all well reported, and that is the reason why diagnosing this condition is very, very difficult. This is a very useful slide. Somehow pneumonia may be typical or atypical. That's what I said in the first slide itself. Atypical pneumonias means the child continued to have URI symptoms like a headache, sore throat, fatigue, mild fever, cough, but child continued to play. Again, child becomes sick, lethargy, like that will be going on. But in typical pneumonia, it is having, I already said, the child will be sick, and abrupt onset will be there. In addition to the fever, child develop dyspnea, and interaction, that is retractions, may be severe. If you count the respiratory rate, you all know it may be increase, respiratory rate increase according to the age and all. Coming to the X-rays, most of the times in Mycoplasma pneumonia, we get non-specific radiographic pictures. You may not get any typical. For example, if it is a Streptococcus pneumonia, you can get a lobar pneumonia. If it is a staph, you can go for bronchopneumonia like a picture. Sometimes when a staphylococcus, you can get some sort of a cyst, cavitation. All these things may not happen here. Most of the times, Mycoplasma pneumonia produce non-specific radiographic features. Sometimes patchy infiltrates. Most of the time, I happen to treat 3 or 4 cases, even last 3-4 months, and most of them develop on the left lower lobe. I don't know it is a correlation or not, and this is a patchy infiltrates. So I treated I think 13 or 14-year-old child, school going child, suddenly become uneasy, started telling I am having some sort of a disturbance in the chest, cough, and this child father's parents found that it's something different, so they brought us, and we never thought the child is having a pneumonia, but the rate also is not very high. So X-ray shows that there is a pneumonia infiltrates on the left lower lobe. And finally, we are all discussing whether it is a slowly developing pneumonia or one of the differential diagnosis is a mycoplasma. So the child is subjected for molecular diagnosis. Then molecular diagnosis came positive. So we avoided even bronchoscopy, and later the child was placed on macrolide. The child become all right. 25% of the Mycoplasma pneumonia present with extrapulmonary manifestations. Actually, that is reason why any sudden encephalitis, we have to think Mycoplasma as one of the differential diagnosis. It known to produce many CNS complications, including Guillain-Barré and post-infectious demyelination, peripheral lymphodepletion. All these things are all well reported. And more than 1/3 of the Mycoplasma pneumonia do present with some sort of the dermatological skin manifestation, either as a rash or erythema multiforme. All these things, even SJS, Steven Johnson syndrome, also reported with that. And one thing is that I already said this organism do produce autoantibodies. The IgM antibodies or act as autoantibodies. They cross-react with RBC polysaccharides. That is, we know our blood has RBC as a surface polysaccharides. It cross-reacts with, thereby causing a clumping and hemagglutination. And that is the way we are detecting or suspecting Mycoplasma pneumonia in earlier days. Mycoplasma pneumonia can be diagnosed by 3 ways: molecular, serology, culture. But culture, I think it not come into the race at all, because culture takes long time. It is very difficult to culture. We need to have a very special media, and again there are a lot of contamination with that organism. It may take even 4 weeks, or that is the reason why culture is not going to help. Serology and molecular diagnosis are sometimes widely discussed. Among the two, many of them either use both, or they straight away go for molecular diagnosis. Coming to the molecular diagnosis, it is a PCR, that is a polymerase chain reaction targeting Mycoplasma DNA, particularly targeting the P1 gene or 16S RNA gene are found to be very useful. And sometime before they thought real-time PCR, that is the quantitative PCR, might be useful and all. But today a lot of scientific publications support RT-PCR. See, because if you detect DNA, then it may be it may reflect both viable and non-viable organisms of Mycoplasma, or the colonization that always there in the throat. That is the reason why people want to go for RNA. Actually, the samples are subjected for reverse transcriptase, then it become DNA. Then RT-PCR is found to be really very useful in this condition. A word about the serology. Serology, we can do either IgM antibodies or IgG antibodies against Mycoplasma. IgM antibodies do happen in the acute phase, but many publications says that it is not happening in the first week at all. Sometimes it may continue to be there even after 6 months. That is the reason it's a real problem. But if you are lucky, if you get IgM positive in a suspected child, you are lucky. Otherwise, you can miss the bus. Most of the studies correlated that IgG antibodies, that is a 4-fold rise in the acute and convalescent sera, that is taken as a standard for comparing even a molecular diagnosis and all. Coming to the multiplex PCR, actually this is a study done, and it supports, but it is done in a very large population, more than 3,000, and they compared IgG paired sera along with the multiplex PCR, and they found that multiplex PCR is more sensitive than serology, and that is why actually this what they use is a 2.1 panel multiplex PCR. Actually, in addition to the Mycoplasma, that test diagnoses many viral infections and atypical infections and bacteria, including streptococcus pneumonia and many viral infections, many usual viral infections. But only thing is very, very costly. Whether we should go for a multiplex PCR for a to diagnose a single Mycoplasma pneumonia is a questionable one. That is the reason why many people say that you should need to have selective kits. The kits that detects only Mycoplasma pneumonia. Already there is on the trial. It is all started available. And why not? Why should the child should be subjected for multiplex PCR? Why should not have a single test that diagnosing DNA of Mycoplasma pneumonia? So already kits are available. Probably validated kits may be available soon and all. This is the panel I said that RP21 panel gives lot of, it detects. Actually, this is not very useful in OP practice. In a particular child admitted in hospital, particularly in ICU, we don't know the cause for the patch. The child is not responding, and the child may be little immunocompromised, or the child is already been subjected to too many antibiotics. Child has been treated in the last 3 months in various hospitals. Then you can go for this panel. This panel picks out very large number of organisms. So you have to go with the clinical picture. Don't read this panel alone. And if you suspect a child with atypical bacteria, sometime it may tell about even Legionella, Mycoplasma, Chlamydia. All these things are all very useful. Only is the cost. So it is only for your knowledge. I think this is cold agglutinin. Sometimes before it is an exam question. I already said Mycoplasma induce IgM antibodies. These autoantibodies reacts with the RBC antigen, thereby causing agglutination reaction, particularly when the temperature is reduced to 4 degrees centigrade. This is a cold agglutinin. There are some, you all know, agglutinin may be warm and cold. Here, cold agglutinin. So the reduction of temperature of the blood or the serum will make the serum to go for agglutinate, and anything titer is 1.64 is considered to be positive. But only thing is this sort of a cold agglutination do occurs with many viral infection. It is not very specific. I mean, a lot of false positive, false negative. Particularly the enteroviral infections, all these things are supposed to cause cold agglutinin and all. But what I say, it may be taken as a standby, or I think I had some special interest on that. It can be used as a screening test till the report comes and all. See, of all the antibiotics, I think children can be subjected for 3 types of antibiotics: azithromycin, doxycycline, and levoflox. But levoflox and all, because of the cartilage defect and all, we are not using. And doxy, you can be used from 8 years onwards. But what they say, azithromycin is the preferred antibiotic in children below 8 years. It can be started with 10 mg per kg, followed by 5 mg for 4 days. I think anywhere between 3 to 5 days and all you can give. And it is because of the immunomodulatory properties, azithromycin is widely used in the world. I think because of the extensive use in some part of the world, it is already showing some resistance. Azithromycin, by blocking the protein synthesis, particularly 23S RNA, it kill the Mycoplasma. That is why it's again azithromycin advantage because it's a OD dose. That's many people sometimes it been wrong. What I say, many times it may put on viral infection. That's the reason for developing resistance. We have to be very careful, and you have to judiciously use this drug. I already said because of the extensive use of macrolide, particularly azithromycin, there is a increasing resistance. In Japan, around 40%. In China, it is reported around 80%. That's a very sorry to hear this news. Even in Europe and even Western world, the resistance is slowly increasing from 8 to 20%. Particularly in the Europe, some countries it may go even up to 30% and all. That's the reason why I think many scientists feel this drug should be cautiously used. And when you strongly suspect viral infection, don't start with this azithromycin. We should not play with the drug, because one day same situation, because if a same situation may arise in India, I think it's very difficult to manage this infection. So when you strongly suspect viral infection, wait for at least 3 to 4 days. The child may become alright, fever may come down, cough may reduce, or the respiratory symptoms may drastically come down. You make the child to put on some vitamin C, or sometime associated illness along with the antibiotics may be treated, and a good sleep will make the child to become alright. So misuse of macrolide, particularly azithromycin, should be taken into consideration. Coming to this slide is a very useful slide, because we should have a working knowledge, because I already shown one of the equivalent saline. Any child presenting with pneumonia like symptoms below 3 months, these are the organisms, particularly Streptococcus pneumonia, chlamydia, group B, Escherichia coli, Staphylo, all these things to be considered. Where mycoplasma comes means particularly after 3 years, okay, or 5 years, mycoplasma comes in this race. There are some special situations we have to think of other organisms also. Any conditions become chronic in developing countries, tuberculosis should be thought of. And if the child is already having a problem, particularly immunodeficiency or cystic fibrosis, or you have to think of Pseudomonas. And a child being exposed to recently that swimming pool and all, you have to think of Legionella, that is also cause acute pneumonia. Fungal infections do occur in Western world, particularly when they near very close to river or forest. We don't know, so many fungals are there. Children get exposed to fungal infection, but usually normally immunocompetent child may not develop, but still we have to be very careful, because aspergillosis is the one, or aspergillus infection is the one that do occur even in an immunocompetent child. And what they say, mycoplasma do go with these organisms. It always go with this organism, and the test shows that the mycoplasma co-detected with many of these organisms. That is what the thing. I don't know, I think lot of validated reports may give you a correct picture. Still, we can say that mycoplasma do happen after 5 years of age in the pneumonia, and it is always go with the other organism as a co-infection also. That you have to remember that. Last 1 or 2 slides. What is the prevalence of mycoplasma? Actually, many people may be skeptical about that. Is it mycoplasma is very common? That is what the question. And when I happen to go through some of the literature, I get some of the very good literature. It is a meta-analysis of 50 studies. That's a very useful one. And that is the reason why I shown that. They found that the meta-analysis found that roughly mycoplasma accounts 10%. That is very important. So you cannot take it, because 50 studies has been analyzed, and finally meta-analysis shows that this mycoplasma accounts 10% in the causing community-acquired pneumonia. And this is another study. This is done in India, New Delhi. Actually, this is also what actually they looking at the IgM antibodies in acute phase of infection. And actually this study also found that by doing Ig antibodies in a clinical background of a particular child suspecting mycoplasma, they found 11% positive. That is very, very important. And they also equally found out legionophilia. So finally they, after extensive discussion, and many other samples do so, some 8 samples shows both the infection. So finally they conclude saying that combination of laboratory approaches is very important. So wherever possible, go for PCR along with the serology. That what is the term. So this is my slide. What I want to say that when you strongly suspect, you want to prove that the child is having a particularly suffering from mycoplasma infection or mycoplasma pneumonia, I think you can use the 3 together. Cold treatment is the one that not going to be cost very much, and only thing is in medical colleges and all, as a part of the microbiology work, they can take this. And only thing is, we have to do Mycoplasma IgM in acute phase along with the RT-PCR. If all the three is going to be positive in a particular child, I think it's definitely you can say that the child is suffering from Mycoplasma pneumoniae infection. I think this is the one that I want to say the youngsters, you can take up this study also, and you can prove at least 50 children if you study with the control, if you prove that, I think this combination works out very well. Finally, this last slide, I think. Remember that CAP, community acquired pneumonia, account 50% of the under 5 mortality. That is very, very important. See, pneumonia is a killer disease, particularly in children below 5 years. 15% of the children do succumb to pneumonia, and it require at least 10% of the children require hospitalization when they develop CAP. I already said many times co-infections with a multiple pathogen is the one that has been very recently reported, and all these problems happen more in developing countries. We have to remember about that. With this, I think I thank my viewers, my friends, my students for this patiently listening this talk on Mycoplasma pneumonia. I want to thank all these stalwarts who are doing extensive work and publish many papers, and with the background, this knowledge only made us to talk this subject very clearly. Thank you very much.